Yeah. Okay. Good evening, everybody. Welcome to our meeting, Health, Housing, Adult Social Care Scrutiny Committee. The usual, where are we? We're in the Thornton room this evening, and so the way out is that way. And we will start on agenda item 1, declarations of interest. So I'll ask members if they've got anything to declare. Councillor Vassy.
Chair, I don't think it's a prejudicial interest, but a member of my family is directly receiving over the past months help on cardiovascular problems and stuff like that. So it's certainly informed my points, but I thought maybe I should just raise it.
Thank you, councillor. Anybody else? Okay. Next up, it's the minutes. So tonight we've got the minutes of the 27th, the last meeting. So those are included in the agenda pack at page 3. I'll take any points to note. So go to Councillor Wilson, please.
It was just to add that in any other business, we raised the point of minuting our thanks to Lewis Rogers and the Navigator team, and that's missed off the minutes. So if it's possible to add that in, just to thank them for their time and expertise.
Yes, James.
Sorry.
I've included it under the work plan because we didn't have any other business as a scheduled item. It's kind of tucked in there, so it is referenced, but I can see about altering that if.
My mistake. Thank you.
Okay, let me just check where that is. Yes, okay. The committee placed on record its thanks. Yeah, no, I missed that as well. So thank you, Councillor Wilson. Thank you, James, for pointing that out. Are there any other points arising from the minutes? They're correct record. Yeah, okay, I'll sign those. And I'm happy to take any matters arising if members have got matters arising from those minutes. We've got the executive member for housing here with us. I think this might be one of the times he has to shine. No, okay, we will move on. I'll sign those minutes. Yes, Councillor Vassy.
It's worth just noting that in the minutes it was saying there was an aspiration to discuss the homelessness strategy, and that you and I don't know if that is in the minutes, but there was certainly a note that the homeless strategy was hoped would come back in April. It hasn't come back, and just to note that as part of matters arising, hopefully it'll come soon.
Yeah, I think that's a good point to note, and we will get onto it in work plan, but I'm happy to take Councillor Pavlovic at this point.
Thank you, Chair, and thank you, Councillor Vassy. The paper has been through a number of revisions, and indeed has just been to CMT exec this afternoon. So the officers are well aware that we need to have that briefing with yourself and with the chair before it goes public to exec. So hopefully that will be next week, but it's just in another revision as we speak.
Thank you both. Okay, we'll move on to public participation. We did have one registered speaker. James, I believe they're not here or not online either.
Yeah, not here. They were going to be speaking.
Okay, we will move on from public participation. We'll go to agenda item 4, which starts at page 11. And I will ask Peter and Philip, is it Philip? Yeah. To introduce the paper.
Thank you very much, Chair. And yeah, just to introduce myself, Peter Roderick, Director of Public Health, and I've got my colleague Phil here, who will introduce himself in a little bit. We're going to do a bit of a double team for both of these papers and just do a broad overview of what's in the papers and then open, obviously, for comments and questions. This first paper, Tackling Cardiovascular and Metabolic Disease, I'm aware it was probably one of the sort of more clinical medical papers I've ever put before a council committee. And in some senses, I don't make any apologies for that, because since 2013, when the council has had responsibility for public health, one area of our domains of public health has been the healthcare public health domain. It's one of the areas of professional practice, and it involves public health having a strong input into the work of the NHS when it comes to generally some of the risk factors for ill health, which are very widespread across the population. So we don't generally in public health get ourselves involved in diseases which affect small numbers of people. To the vast majority of our work really does focus on those diseases which have that large disease burden that at a population level you can do something about. And that's why actually this paper is on the table, and one of our commission services is aimed at tackling those two of those very, very widespread diseases, cardiovascular disease and metabolic disease. But actually, we have a broader remit around making sure that the whole system is working to tackle those. So that's why this paper is on the agenda, and it does move through some background information on the disease and trends in disease into talking about our specific programme, which is the Healthcheck programme, and Phil will cover that. But just before we get onto that, just taking us through the first part of the paper, the background, and really talking about the work we do both to tackle the risk factors for some of the major diseases in the population and to tackle the early stages of those diseases and supporting people to live with those diseases in the early stages to prevent their progression. And we do this because they're some of the leading causes of early death. So, for instance, stroke and heart diseases are responsible for around a quarter of the deaths in the city. So we're talking about those sort of wide scale problems, and also they cause inequality. So the paper points out that people in the most deprived 10% of the population are almost twice as likely to die from cardiovascular diseases as those in the least deprived, and very much aligns with some of the things we've written into our health and wellbeing strategy therefore. So when we talk about prevention for cardiovascular diseases and metabolic diseases, and actually the two are related because the body's circulatory system and its digestive and endocrinological systems are very interlinked. I think we're understanding that more and more as the evidence grows. Those diseases, we generally look along a kind of a tiered model of prevention and think about primary prevention, secondary and tertiary. Won't cover tertiary so much because it's not really where public health efforts focus, but just some examples of what we do around primary prevention of these diseases, just in three key areas. So we think about high blood pressure. It's astonishing actually how large a proportion of the population lives with high blood pressure and how relatively few people in the population know that they do. Blood pressure is in some senses a silent killer, and working to support people to know their levels. Taking a blood pressure reading is fairly simple, but not completely simple. And you have to do it in a particular way and getting it done right, and supporting people to encourage them to do that. But crucially then doing something about it. It's no good knowing you have high blood pressure, thinking about the lifestyle changes you can make. And actually, there are, for many people, actually drugs that can help them control their blood pressure that they're not currently on. The second is cholesterol, and essentially, there are good forms of cholesterol and bad forms of cholesterol. A cholesterol test will tell you essentially the good minus the bad, and if you're over a certain level, will tell you have high cholesterol. Again, there are things you can do within your lifestyle which enable that cholesterol level to reduce, but there are also a very commonly prescribed form of drug, probably one of the most prescribed drugs globally, a statin, which can lower the cholesterol. And we know a lot of people are not on the statins that they could be on, and therefore we're missing out that opportunity to help prevent. And then atrial fibrillation, which is essentially a heart condition which places you at risk of stroke. And again, there are drugs we can put you on if you meet certain criteria for that. So we focus on primary prevention. That's when people don't know that they have anything wrong with them. So finding disease essentially within a population. Secondary prevention is when we know that somebody has an existing disease. They might have had a history of having a heart attack, or they might be genetically screened for something called familial hypercholesterolemia, or they might have type 2 diabetes. And having found them, we need to make sure that the treatment they're on is maximized. So that's secondary prevention. At point 9, I put some broad national targets around what our ambition is in these areas. So for instance, high blood pressure, we know that Canada for decades has found 4 in 5 of its population with high blood pressure, and the UK has generally averaged around sort of the 40 to 50 to 60%. And it has been going up. We're nowhere near what Canada's just been able to achieve. So there are some national ambitions in all of these areas which are set out in the paper. I put a little bit about the trends, and there is a table in prevalence, which I certainly won't go through because there's a lot of numbers there, but just for information for the committee, our prevalence figures, how they compare to national. In summary, we have higher rates of disease which affect people towards the end of life, so heart failure and stroke, and lower levels of disease affecting people earlier in life, hypertension and atrial fibrillation. But I would say that's comparing us to national averages. Actually, I'd still say there's an awful lot of high blood pressure in the city. We need to go out there and find and help people to live with better. And I put some data in there about trends in terms of how some diseases such as heart attacks and strokes have actually reduced over the decades in York. Other diseases, type 2 diabetes would be a very interesting one, has hugely increased. It always sort of never ceases to amaze me. In the last 12 or so years, we've added 8,000 diabetics to York's population by diagnosis in general practice. That's a population of 200,000. That's quite a large number of people. And then some more information on inequalities. So I've outlined the problem a little bit. Health checks are certainly not the solution, but they are part of the solution. So I'll hand over to Bill, who's going to summarise the health check programme.
Thanks very much, Peter. So yeah, I'm Phil Truby, public health specialist, part of Peter's team, and I oversee the health checks contract that we have. So as Peter started to allude to then and is detailed in the paper, part of the problem is this diagnosis gap. So we have, there'll be X number of people with a certain condition out there in our residents, but not all of them will be diagnosed. So we know about the people that we know about, but obviously there'll be a proportion of those who haven't had any sort of screening and are therefore undiagnosed. The NHS health check was in part to help detect those people and to be able to deliver some form of intervention for those. So it's a national programme. It's targeted at people aged between 40 and 74 who don't already have one of the health conditions that we're trying to diagnose. Obviously, if they've already got it, they should be receiving treatment for that. It's a statutory duty of local authority public health teams to either deliver or commission NHS health checks. And locally, we have a contract with Nimbus Care to do the delivery of that. NHS health check is basically a routine sort of screening of a few different clinical tests. So height, weight, blood pressure, bloods, and then some questions around sort of alcohol consumption, physical activity, etc. It gives an overall picture of someone's cardiovascular and metabolic health. Within York, that sort of, we talk about the eligible population, so those who are in that age cohort but don't already have that existing medical conditions, and it excludes people who are in prison as well. So our colleagues at the Office for Health Improvement and Disparities calculate a value each year for the city. So for York, it's around 55,000 people will be eligible for their NHS health check each year. Our contract with Nimbus stipulates that they can deliver 2,000 health checks a year. So, across a 5-year period, we will be delivering 10,000 health checks against an eligible population of kind of 55,000. Obviously, it's an ambition to be able to offer to all those people. It would never be expected that you would deliver to all of those. Not everyone is going to have the offer taken up. What we've decided to do locally is to target the provision of those health checks to where we feel that there's greater need. Obviously, it's a universally accessible service, but we have stipulated within the contract some additional targeting criteria to try and get the best, I guess, value, best yield out of those. So people who wouldn't have otherwise traditionally engaged with an NHS health check. Some of the criticism prior to that being implemented, both locally and nationally, is a term I don't particularly like, but around the worried well, people coming forward who are generally well, but just seeking reassurance that actually everything's okay. So the criteria that we've stipulated in there are around people who are living in the 50% most deprived areas of York, people who are already obese, people who are current smokers, people with an elevated alcohol risk, or people with a diagnosis of anxiety or depression. So it's still quite a large cohort, but it is targeting our provision where we feel it's needed most. We have kept some provision in there for the universal access of that. So, if somebody really does desperately want a health check, they can contact Nimbus Care and still get booked in and receive their health check. We awarded the contract kind of towards the latter part of the COVID pandemic. So it was still a bit up and down in terms of service delivery, but Nimbus have held the contract since October 21, and up until the end of March, they've delivered just over 5,000 health checks. I think a key point is that the contract stipulates that they need to then refer on eligible people into our health trainer service. It's fine if we identify people with a condition, but then what are we going to do to support them longer term? Some of that will be back into primary care and, prescribing a medication if it's a statin or something else, antihypertensive, as Peter described. But a lot of it could be around that lifestyle behaviour change. And that's where we are sort of the experts in that. So why not refer them and link them back into the health trainer service? And then the final part of the paper is just highlighting the other sort of offers that we have that complement the health check programme. So our community pharmacies are signed up to deliver hypertension case finding. We're just submitted a bid to deliver health checks in workplaces. We're waiting to hear the outcome if we're successful on that. And there is a digital health check offer slowly working its way through, which we hope to be able to implement soon. Thanks very much.
Thank you, Peter and Phil. Really appreciate your overview there. I would like to open out to members for comments and questions. Just jump in and do a tiny bit of housekeeping, which I missed off at the beginning. We did have apologies from Councillor Kelly and Councillor Rose, and we've been joined by Councillor Melly and Councillor Burton, respectively. So welcome to you both. Sorry to not do that at the start. Have we got members that have got questions for Peter and Phil? Okay, some good hands there. I'll go straight to Councillor Steels-Walshot, please.
Thank you, Chair. Thank you for this report. I think it was the bit that I was looking at was the proactive invite residents. And I just wondered if we're looking at people in higher risk groups, was there any scope to further make this go further to higher risk groups that are sometimes harder to engage, such as gypsies and travellers, people using drugs and alcohol? And I wondered if there was any plan to go there. And I know there is the thing of the audit score of 5 on there. That, to me, that's a fairly low audit score. And I was just wondering, does that fit within a time scale of when that was done? Could that have been done on, because people's alcohol use changes, and could that have been done many, many years ago? So yeah, sorry, there's kind of 2 questions in there, but thank you.
Well, I'll pick up the first one. If you want to do the second, is that around audit? So I think it's a really good point, Councillor. I think there is something about the feasibility of this with our primary care partners, that the budget was exceptionally tight and they're offering a health check for quite a low value per health check. So for us, I think we wanted to ask them to target, but also they had to do it in the context of existing clinics and an invite in. And I think one thing we are very keen to do as we move the sort of public health team forward in our work is to look at how services which previously we conceived as often being, we sit in a clinic and we invite you to come. Actually, we know that those don't always serve everyone in the city as well. And within very tight budgetary sort of sort of resource is how we find ourselves out in communities delivering things. So I think it's something that we'd like to see increase. I think there have been some opportunities to do some of the work you describe, and actually I think as part of models around drugs and alcohol, for instance, I would say that, you know, the clinical aspects of the contract we have for drug and alcohol services and inclusion of cardiovascular risk within that has been on our radar for some time. Again, it's just about how do we resource that type of work. In terms of sort of other marginalised communities, there, I definitely think with work we're doing, you know, cross city on a health needs assessment for gypsy and travellers in the city, I think we do have to challenge ourselves and primary care to say, how do you make sure that, again, with communities that sometimes haven't trusted for good reason health services, how we build that trust and relationship? Sometimes that isn't come to us again, it is we go to you. So I think slightly waffly answer to say that. I think the points are absolutely right. The resource constraints mean that I think we explore as and where we can doing the things you suggest, and look to see, you know, each of the populations that we can. I would say 2 inequalities populations, a crude term, actually receive an offer which is different from what we've outlined here. So this offer is for 40 to 74-year-olds in the city, but those who live with a severe mental illness and those who have a learning disability get their own version of this, which is actually NHS funded. And that's why they're not included within our, for instance, we've talked about people who have depression and anxiety. We don't offer this for those who have schizophrenia or bipolar disorder, those sort of diseases, because there is an NHS offer already. Did you want to pick up the alcohol one?
Yeah, happy to. The threshold was set, I guess, with the audit score low enough to be a catch-all. You're absolutely right, though. It's only as good as the primary care record, which we know for alcohol scoring is, you know, not 100% and can often be fairly old, because, you know, it can often be done when someone is first registering with practice. So there is absolutely the scope to look at a revised score on that, or the time frame in which that score was sort of recorded on the system. And when the provider are running searches, they do try to use the most up-to-date data from the primary care record to support that targeting of the invites.
Thank you both for your answers there. I've just got a couple of members to jump in on this point. I'll start with Councillor Baxter, and then I'll bring the executive member in and Councillor Wilson as well. Councillor Baxter.
Thanks, Chair. It's similar point to Councillor Steels-Walshaw that a lot of the time the communities are harder to reach to. I don't know if you've heard of the campaign in Barnsley called How's the Ticker? And it's based, it's about getting people, in true South York fashion, getting people to check their blood pressure. And they go to sort of barber shops and the markets and things like that. And it's really effective. They've already tested 5,000 people in a year and a half. And I think it's important that we go into those communities rather than them expecting us to come here. And, you know, barber shops, it's a great way to also have a conversation, an open conversation.
Peter.
I might come back on that, Chair, just to mention something isn't in the paper because we were concentrating, I guess, on our council commission stuff. But what I do know is that, and I think in some ways we've been influencing the NHS's thinking on this, that the ICB and in the Integrated Care Board, in partnership with our primary care colleagues in York, have a cardiovascular disease programme, which is a bit more at the, I guess, at the tertiary end of the things I described, but also has a primary prevention element. And one thing that has launched in the last 6 months, which is, you know, it's not as well sort of branded as How's the Ticker, which sounds, you know, we should copy that, but is very much along those lines, Councillor, is the health kiosks. And health kiosks have been in surgeries a lot. You see them all over York, the sort of step on the scale, put your arm in the blood pressure monitor, have your pulse done and your temperature done. But they're always in clinical settings. what the ICB's programme is doing is putting a kiosk in, get this entirely right, Tanghall Community Centre, the Morrisons on Foss Islands, and I think Energize, I think that's the third. So we only were able to fund 3 of them. Actually, the money for that came from a joint pot between Public Health and the ICB. We're evaluating the use of those kiosks in order to see if that could be a really effective way of reaching communities. Particularly, we found some people, I'm not going to say men, but probably more likely to be men, actually more likely to come forward if people don't see you doing something. So it's almost like the sort of have a bit of a go because you're out and about in town, but it's not a booked appointment. It doesn't raise that sort of that threshold of needing to go to see your GP for something. Actually, other areas have seen that's quite effective. So I think the idea is very welcome for imaginative ways of reaching people about blood pressure. I totally agree.
That's a really good point. Thanks for that, both. I will bring in Councillor Runciman and then Councillor Coles.
Thank you, Chair. I want to ask about the digital health checks, and particularly want to ask about reaching out to communities where there isn't a digital connection and those that are digitally excluded. And I don't know if you or Phil could respond about that, but it does sound interesting, but it won't reach everyone.
Happy to take the response on that one. The digital health checks programme is being piloted nationally rather than locally. It was announced, I think it was last summer now, by the government around that they were looking to roll out a digital health check programme. It has been piloted in one local authority area down in the south in Cornwall with moderate success, and they're moving on to a second, we're calling it a beta phase, where they've got 3 further local authorities involved, not us, to look at expanding that and the feasibility of that. You're absolutely right in that it won't reach everybody, and I don't think it should be seen as a replacement to the local authority offer. It's more of a complementary thing to that. So there will be a segment of the population where the digital offer works really well for them, and that's great, and let's offer that to those people. But let's keep this offer, and what we want to have ultimately is a 2-track offer where we have a digital offer that's kind of almost our universal offer, and then this becomes our targeted offer to those underserved communities.
That's good to hear, Phil. Thank you.
Okay, Councillor Coles.
Thank you, Chair. And just to add, particularly on the kind of health checks point, that we're particularly keen to ensure that we have repeat offers for marginalised groups, that it doesn't become something that is a one-off from primary care that just goes out once and therefore a certain cohort will respond and engage, but actually there'll be a more harder to reach cohort that actually might need repeat efforts to communicate or to reach out. So I take the point about the NHS funded work, but actually even within that, there'll be certain groups and individuals who might need an assessment or might need more pressure to attend to have an assessment. And actually, if we're serious about reducing health inequalities, finding things early and being able to intervene early, it's actually really important that people are able to access those appointments as early as possible. And then the other point I was just going to make around whatever our offer is, we just need to be really clear about what our comms are around it, and that we're ensuring that that is reaching out into the community, as well as the direct communication that's going out to people who are being invited to a health check, actually ensuring that people are aware that those invitations are going out. And if they don't see the letter through the post or whatever it might be from the GP, that they also see the particular groups that are being targeted from our comms from the council and the ways in which we can do that.
Thanks for that, Councillor Coles. That's really important points, particularly on your health inequalities, which you've mentioned to committee a number of times before. So really, really good 2 points there. Thank you. We'll go to Councillor Burton, please.
Thanks. Yeah, I was going to bring up a similar point to Councillor Baxter, but I think just on the health kiosks, I think there may have been some challenges with delivery and communication, especially at Tanghall Community Centre that I'm aware of. So it'd be worth checking in about how that's going. I'm there on Friday, so I'll ask the same questions. But I think that might not have got as much use as it should be getting, just because of the way it's been communicated to residents. So it'd be good to check in on that. The only other point I had on this one was more on the preventative side with cardiovascular. I think it's not mentioned in the paper, but a big driver is air pollution, right, as a background kind of indicator of this. And I guess just the kind of, I hope you're putting across the case when it comes to things with transport colleagues and other decisions being made in the council, that public health are making their voice heard about making sure we make the right decisions for reducing air pollution and encouraging active travel, so that that's being driven forward. Yeah.
Thanks, Councillor. I can respond to that, Chair, just to say absolutely. And, you know, we're bringing forward an Air Quality Action Plan 4 as an authority, and Public Health have been very involved in that. And one of the key drivers for that work are the 90 deaths a year attributable to poor air quality in the city, 90 out of 2,000 on average every year. It's quite a large number of our deaths that come from poor air quality. That are not the direct effects. Very few people have that on their death certificate. It's a contributory factor that underlines so much ill health. And given cardiovascular disease is sort of 1 in 4, that's going to be quite a lot of that. So absolutely, thinking about all the mitigations we have in our power to reduce NO2, PM2.5, all those nasty sort of chemicals. And you know, in public health, we look at often at our international sort of standards, and the international standards there would be what the WHO classifies as the reasonable level. So we're very plugged into that piece of work, and we'll certainly also look at the Tanghall Community Centre work and see what's going on there.
Okay, Councillor Melly, please.
Thank you, Chair. Do people in prison receive some sort of equivalent health check and healthcare as part of a different programme? Is that why they're excluded from this programme?
I believe so. I mean, I think prison health is commissioned by a national organisation and often delivered by large providers who cover multiple prisons. My understanding is that, you know, health needs in prisons are huge, but in general, actually, prison health care is fairly well resourced, albeit I'm sure there are places where that's not true. Often part of the issue actually is continuity of care when people leave prison and come out, and, you know, their mental health issue that they've been receiving support for, their drug and alcohol addiction, whatever it is, that's a big area for me, thinking about our public health services that I'm keen to work on. I'm not, and we're not as an authority responsible for that health in prisons. So I guess we work with our national partners to make sure that when there are, you know, and there obviously are, there was an open prison in York, you know, when we have those within our boundary, we're sure that the population are well served through healthcare. But that, I don't have the exact answer about what the cardiovascular check within the prison estate would be. So I can certainly get, I mean, Phil knows, or anyone else around the table knows, but we can get that answer to you, Councillor Melly, in terms of that obviously the exclusion is more than anything from this programme, a practical one made nationally, that it would have been impossible to include that within the National Healthcheck offer.
Okay. Yeah, I mean, I would be reassured to know that we're not just excluding them because that's what government have said, but we are checking that actually that they are still in our population and they also need to be served by this sort of.
I can check with our colleagues in OHID, actually. I mean, maybe Phil probably knows.
That's it. There is a programme. It was commissioned previously by Public Health England, moved across to OHID, and it's for prisoners serving a sentence of 2 years or more. There's a structured health check programme in place for them, which is broadly similar to the NHS health check. I think the age range is slightly lower. I think it starts at 35. I think it's 35 to 74. And there are quite stringent targets around that, around offering an uptake and the things that are included within that. I guess for people who are serving a shorter sentence, they will be back within the community and therefore be picked up through the normal programme. You know, it's a rolling 5-year programme of eligibility. So if you're in and out within less than 2 years, you're back in the community, you should be picked up by this programme. So yes, there is a provision in place.
Councillor Vassie.
Thank you, Chair. And my comments are informed practical insights of looking after a family member who's been into hospital 5 times since November, primarily with heart problems. So we all know the huge cost to the city in terms of adult social care, and we all want to see better outcomes for patients and seeing the money doing more than it is. So 3 insights. One is the telling your story once thing that comes back to this committee time and again. In practical terms, I've had to tell my family member's story on multiple occasions due to that member's vascular dementia. Information isn't really being shared as effectively as it might be between the council, social care services, community nurses, GPs, the district hospital, and all the other people who are involved. And that essentially leads to time being lost over and over by a whole load of very busy professionals. Relating to that, ensuring that information about medication is shared effectively is a challenge. Ensuring help in getting blister packs so that different members of the healthcare professionals can administer the same medications. That's proving difficult. For anyone who doesn't know what blister packs are, they're simply a way of organising all the medication that an individual has to take through the course of a day into individual pockets so that any professional can come in and see the person requiring the medication, have confidence that they're giving the right medication, that it hasn't previously been given by someone else, etc., etc. So that's proved quite difficult to organise. I say it was in relation to someone with dementia. That's also an issue because ensuring that someone takes their medication is complicated. So with cardiovascular problems, you can prescribe the medication, but if there isn't someone there to make sure that it's taken, that can result in a patient ending up back in hospital. So just wanted to make that point that's a challenge. And the last one I'll mention, if I may, Chair, is relating to blood tests. My family member's been in, as I say, 5 times since November. On 2 of those occasions, paramedics have indicated that if they had the right equipment, they could carry out blood tests at the home of my family member instead of having to take them into hospital, where they wait typically 5 hours with the paramedics who can't do anything else in order to conduct some tests that could possibly have just been done at home. And so I saw that as something that I think would help in terms of time, in terms of money, in terms of outcome, in terms of the comfort of the individuals who might need help. And as part of this whole drive, which I support, of trying to enable people to stay in their own homes. So I hope those are a few practical things that I've learned that you may respond to or see as things we need to do more about.
I'm happy to pick up a response to that, Councillor Vassie. I think what the issues you're describing there are very much part of where society and medicine has gone over the last 30 to 40 years, where previously, generally, people maybe got 1 or perhaps 2 long-term conditions in the course of their life. And now we're really, we're seeing the population generally getting a good number of long-term conditions with a lot of complexity, with multiple services involved. And I think that's part of the picture that programs like this are trying to prevent to some extent, and not all of it is preventable. And it's important to state that, you know, even though some of it can be, some of it can't be. So we've got to do this prevention stuff, but we've also got to work on transforming health and care into a system that can cope with to use the jargon, multi-morbidity, can cope with people with multiple long-term conditions. You describe a lot of challenges around medicines. That's a huge issue for the NHS. The number of people who are on 10 or more medications is rising. There's a lot of what they call drug disease interaction, drug interaction, the problems that multiple medications cause actually interacting with one another, and you start taking a drug to stop the side effects of another drug that you're on, and it becomes a sort of a vicious cycle. And there's a big movement to try and de-prescribe, actually, instead of prescribe, to take people off. Some of the drugs that are prescribed that I've mentioned in the paper, for instance, a statin, you might have it prescribed at 50. But if you get to 80, 85, and you've got 4 or 5 different medications you're on, it's questionable actually how much a statin is really going to improve your quality of life. And it might be good to take you off it, but that isn't really done. We don't take people off drugs often when we put them on. So I think this is a challenge for the NHS, is dealing with this complexity, and it's a big sort of it's a big societal shift. You know, we're projected to grow the population by about 10% by 2040, but the proportion of people with multiple conditions is expected to rise by 40%. So it's a kind of 4-fold difference in, and that's mainly because people are generally, the population is growing at that older age range where people get those multiple conditions. So it's a big challenge for the NHS. Personally feel slightly relieved as Director of Public Health I don't have to deal with the whole challenge, but I think what we can do is this bit of it, to try and work as much as possible so that when people get to 80 with maybe a cognitive decline or impairment or dementias, they don't also have preventable cardiovascular diseases. They don't also have diabetes to live with. They don't have chronic kidney disease as well. So we don't have as much of that complexity as we see.
I just wanted to come in on one specific point there. You said about a very logical observation around bloods, and, you know, ambulance staff being able to take those, and, you know, while that's not unfortunately within our gift, although, you know, a really good recommendation, we adopted a similar sort of sensible based approach as part of this contract, whereby as part of the health check, you know, it stipulates that you need to have a recent lipid profile, so your cholesterol risk, etc., and if indicated, a diabetes risk as well, and both taken from a venous blood sample. And we just said, well, actually, oftentimes, a lot of people have been in and had a blood test recently. So we've stipulated that if there's a recent blood marker already on someone's record, just use that. You know, let's
6 months.
The last 6 months. Let's utilize the, you know, the resource that's already there and the information that's already there. The same with some of the other indicators. Actually, if they've already been very recently recorded and reflected, and, you know, we're confident in the robustness of them, then absolutely let's use those. Let's not add extra wastage by doing something twice just for the sake of it.
Yeah, on these points, yeah, Councillor Vassy, yeah.
Yeah, so to those last points, I understand what you're saying about the demarcation between different parts of all of this. What I see, what I witness, is someone going into hospital, their condition declining, because that often happens, and then trying to organise them coming back out, and that can be a delay, and then you've got to get community nurses, and then you get social care, and then there are reablement programmes, and there are all different levels of individuals and organisations involved. And what you've just described there, you know, making sure you're using previous tests, just things like that, what I'm witnessing would seem to suggest that you could have a huge impact on the cost and disruption for individuals and for social care services and for the NHS by finding ways of organising that collection and dissemination of data differently, so that people weren't finding themselves waiting 2 or 3 days in a bed, confused, not knowing why they're there, wishing they were at home when they've just gone in so that a series of tests could be carried out. So I hope that integrated care will enable you to be a voice for knocking heads together on that, for the benefit of all the agencies involved and the individuals who are being walked through all of this. And there must be thousands of them over the course of a year, I'm sure.
Thank you, councillor. Okay, we'll move on to councillor Melly, please.
Thank you, Chair. I had a very similar question to Councillor Steels-Walshaw about how people are being identified to receive their invitation and be targeted, and I think you mostly answered that question. Because yeah, there's certain people in certain communities who are less likely to already be registered with a GP, or less likely to, if they do have a health concern, access their GP, and so are less likely to have these conditions picked up, and they're the ones who most need to be targeted. And I think you've mostly answered that question. But then the next step is, once you've identified certain people in certain communities who need to be targeted for this programme, is not just inviting them and then reminding them they've been invited, but actually looking at why they're less likely to come forward for these sorts of healthcare, and actually looking at what the barriers are and how to remove them or reduce them. So could you tell us a bit about, so for example, there's certain communities who maybe are less likely to be proficient at reading and, you know, understanding a letter when they receive it to invite them, or yeah, like communication is, I think, usually the biggest barrier, isn't it? So for example, deaf people experience all sorts of horrendous communication situations when accessing healthcare. So I was just wondering if you could tell us a bit about how those barriers are being identified and removed, rather than just finding the people who face the barriers and inviting them, but actually removing the barriers that they face. Thanks.
Yeah, I mean, it is a difficult one. A lot of the current identification is done through primary care records, absolutely. So, you know, exactly as you described, those people who are already on clinical systems, who are already registered with a GP, already have that information in the system, and they're the ones that are being identified within these criteria. I think, as Peter said before, it comes down to the budget and resource that allocated to this, and you know, it becomes a lot more time intensive for the provider to reach out more. Having said that, we are working with them to look at how we can really broaden the scope of the invites that are sent out and how they're communicated, and what the methodology is for using those. You know, is it via text message? Is it via letter? Are the letters accessible? Is it in plain and simple English? How many follow-ups? How many reminders? And a piece of work has been undertaken nationally around Healthcheck. It's called Healthcheck segmentation, and it's basically split up the population into, I think, 7 different cohorts, and identified the sort of the personas that would sit around those, and therefore good ways to engage them in the health check, what sort of communication preferences are, what the sort of motivational messaging will be, you know, what is the hook that would draw somebody in to engage in a health check. So we are looking to embed that into the health check programme going forward, and look at moving away from a sort of a standardised approach and towards a more person-centred approach.
And if I just add to that, I mean, I agree with Phil. We've mentioned budget and resource, so being rather crude about it, we do all this on £50,000. So it's £25 per health check. And you think about the clinical time that it takes to do the health check, plus the sending bloods off to the laboratory, plus all the communication invite. It's a very, very tight budget for this, for York. And we can't afford to do as many as we'd like to do in terms of the numbers. So part of, I think, our role is all that Phil has described, plus trying to generally work to influence our healthcare services to be as accessible as possible. And it's why actually going to the primary care provider, which is the collaboration of the 11 GP practices in York, to deliver this makes a lot of sense, because they don't just do this, they obviously do a large range of other clinical services, and trying to influence Nimbus, who are an excellent partner in my view on this, to try and make sure whatever they deliver, whether it's this, whether it's women's health services, whether it's out of hours GP, that they absolutely have an offer for those that need British Sign Language, absolutely have an offer for those who need Braille, absolutely have an offer for those with a learning disability, etc., to try and make sure that all of their services, including this contract, is are as good at tackling health inequalities and making things as equitable as possible. So I think it's probably 2 prongs. It's about challenging us, I think, as public health commissioners, about how we particularly communicate this offer. And actually, this has been a super helpful conversation about things that we could do and population sort of bits that we could go to target, but also our role in challenging partners and making sure partners offer those equitable health services.
Thanks for that. Councillor Wilson, did you want to come in?
Yeah, it's sort of related, but a more general point, really. You were talking about how successful Canada have been at identifying. Is it just that they are spending more money on it and that is what's leading them to be more successful, or are there any sort of things that we can nick from the Canadians that would be useful for us?
Well, I think having a national target on this and being able to add high blood pressure as almost a risk factor in the public's imagination. I think if we went, I don't know, I'm the expert on this, but if we went out to the streets of York and talked about what are the key things you can do to improve your health, I think people would immediately say things like, oh, just make sure you don't smoke. And they'd probably say, oh, I need a healthy diet and I probably ought to get physically active. But I think it takes a long while for it to get to the sort of the public consciousness, the idea that actually checking your blood pressure at a regular, obsessive about it, but doing it every year over a certain age is probably a good idea. Don't think that's entered the consciousness in the way that it has done in other countries that have gone big on this from a comms perspective. So I think, aligned to that is the ability to check your blood pressure. And for some in our city, actually, those monitors are not particularly expensive. They're generally around £20 to buy a blood pressure monitor. I'd encourage people who can afford to buy their own and to have it at home, freeing up the sort of resources the NHS and public health put towards those for whom that would be a prohibitive expense, because we need to make sure that they're in particular given that opportunity. So I think there is something about the public consciousness around high blood pressure, which has not been as successful in the UK in terms of public health campaigns as, for instance, quitting smoking has been.
Councillor Bassey.
It's following up actually from Councillor Baxter's points earlier, and about going into communities. The points have been made by various people. When I met with Nimbus Care about 2 years ago, possibly, they had a dream of something they called the Nimbus, as a nice pun for them. And I think the intention was that they would be able to do outreach and engage with the community differently. And what's been said here today reminds me of that. And I'm just wondering, in relation to all this cardiovascular stuff, what the opportunities are for visiting communities in that kind of a way when there are, for example, community events going on, whether it's the circus arriving in the north of York, or the fair arriving in Acombe, or community fetes in rural areas, and whether there are opportunities there that we could do something about to get to people where they are doing something else, and offer them this opportunity of enjoying the miracle that is a blood pressure test as part of their community day out.
I think the answer is yes. There's some great ideas there, Councillor Bassey. I like the pun. We did have blood pressure checks, for instance, at the Health Mela last year, which I think was really positive. I think more opportunities like that, absolutely, we can take away and explore, what we can come up with. So it's a really good set of ideas.
Thanks for that, members and officers, directors. I think that was really good conversation, as Peter's alluded to. All my questions that I had have been asked by other members. So I guess trying to round it up a little bit, I'd like to ask for the committee to note the report and maybe throw a couple of recommendations at you to take away, if that's okay, just based on the conversations we've had. So a recommendation to review targeting criteria for future, to include further accessibility with harder to reach groups. We could say including Gypsy, Traveller, Roma communities. and those with substance misuse as well. I think particularly those two strike me as being important ones that haven't been mentioned. Is that okay, members? Okay, I've got another two just to throw at you. One of them might not work. A recommendation to review. How's the ticker? What is it? And other community engagement, health, public health programs. We talked about your work at the mailer and other community events. If we could make a record of that, is that okay, members? What's the last one? If I could just ask maybe Councillor Burton if it's worth throwing in there a review of Tang Hall. I don't know what might be happening, other communications around that. We can leave it off if you feel it's not necessary, but I just want to, I've written it down.
I think it'll happen. The review isn't. I think. Well, that's how you put that if you want. I'll be there.
I mean, Chair, I'd say we'd really have to take away that action. I guess I would just note that that's not a public health commissioned piece of work there, but what we can do is go away and check with our ICB colleagues and get back, particularly, I guess, to ward councillors from that ward as well. Obviously, interested to know how that's going.
So that'd be a recommendation to review the outreach kiosk at Tang Hall Community Centre. Okay. That's it from me. If that's all right with members, we will close that agenda item and move to the next one, which is agenda item 5, an update on vaping in York, and that starts at page, a general mumble there. I don't know. Page 21. Okay. Thank you. Could I hand over to Peter again to introduce the paper?
Thanks, Chair. And again, Phil and I will overview the paper a little bit and then lead to questions. Another hot public health topic, and I'm sure of interest to lots around the table. So we're talking about e-cigarettes. I'm going to use the phrase vaping just because it's simpler and it's generally what people refer to. We know that I think vaping is one of those public health challenges which requires a lot of thought and nuance. And if I sort of would direct a conversation in any way this evening, it would be around sort of keeping that balance between the twin things we have to bear in mind with vaping. You know, on the one hand, we do have really good, strong evidence now that vaping is probably the most effective tool at helping existing smokers quit, given that cigarettes kill half of their lifetime users. That's an important thing that we must bear in mind, and we can't, in many ways, we can't take action which imperils the usefulness of the e-cigarette and helping people quit. And on the other hand, very understandable and correct concerns about the increase in children, young people vaping, and those who've never previously been smokers and those at often at the youngest age taking up a new habit which is addictive, for which we have a body of scientific evidence that helps us understand low levels of harm but not no levels of harm, and because of that, and because of the fact that, you know, for things like this often you have to wait decades to really understand harm, the precautionary principle within public health would suggest that we probably want to very much recommend children and young people not taking up vapes and non-smokers not taking up vapes. So it's in some ways a public health message for one bit of the population, which has to then pivot to a different public health message for another bit of the population. And that's not always easy to do. I hope the paper in some way articulates those two. The paper does go on to talk, first of all, about smoking and the fact that, you know, it's one of the public health success stories of the last 20 years that we have seen that steady and consistent decline in smoking prevalence. From in York, for instance, we were getting on for 1 in 5 of the population smoking as recently as 2013, and now we're talking about less or fewer than 1 in 10. Which is a wonderful achievement, which, you know, our local public health team would like to take all the credit for. But in reality, it is a combination of local public health team work together with many national legislative changes. We do, though, have this target of reaching 5% by 2030, and at the moment we're at about 12 to 13%. So we have a long way to go, and at current trajectory, actually 5% is more likely to be achieved in 2040, so 10 years later. The paper outlines some of the harms from smoking, which we've talked about in previous scrutiny committees and probably don't need to go through. And then it goes on to talk a little bit about vaping and the trends in vaping, and the most recent estimates of around sort of 4.7 million adults vaping in the UK. So potentially getting on for 1 in 10 of the population, the adult population, who are now regularly using vapes. You know, that's a health trend, I think, that has arisen very rapidly, and we're all trying to get a handle on exactly who those people are. Are they ex-smokers? Are they new vapers but never smokers? Or are they people who are both smoking and vaping? And there is a lot of data out there which the paper summarises a little bit. It also talks about children and young people vaping, which seems to suggest that we had a rise in children and young people vaping. It plateaued and it has gone up since the pandemic. But still, in general, the vast majority of children and young people vaping are essentially experimenters. So when the surveys say that they vape, what that means is that they report having ever vaped or they've tried vaping. There are around about 4% who are vaping more than once a week and 4% who are vaping regularly but less than once a week. So it's definitely a rising trend. But sometimes, you know, 25, 30% of the population, if we hear figures like that, actually, that's about experimentation. The paper talks a little bit about some of the trends nationally, which I won't overview because it's in the paper, but it also talks a little bit about some of the trends locally and what we see, particularly through our school survey. I'll let Phil summarise that. Before I do, just to talk a little bit about the health impacts of vaping and some of the evidence on that, and almost a little bit of a reassurance about what we see. And we have given within the paper a bit of an overview of a summary, a briefing from Action on Smoking and Health, ASH, which is a bit of a myth-busting sort of set of evidence. And I guess this is because the public health authorities globally have been a little bit mixed on some of their guidelines on vaping. And generally, it's fair to say in the UK, a lot of our health authorities in the paper lists the Royal College of General Practitioners, of Obs and Gynae, Royal College of Physicians, NICE, Public Health England, Royal College of Midwives, have generally recommended vaping as a highly effective tool for quitting. But internationally, WHO and the Centre for Disease Control in the States have been a little bit more cautious. And so we put in some of the science behind vaping and some of the myths which are often circulating about the use of vapes. For one, vaping nicotine is more harmful than smoking tobacco. That myth is pretty comprehensively disproven. And if we just look at the number of deaths per year due to smoking versus the number of deaths due to vaping, we know that whilst nicotine possibly can consist of, represents some health harm, it's generally the other chemicals within a cigarette which are causing the harm, not the nicotine. So carbon monoxide, tar, and particulates are the thing which really harm the lungs and cause the cancer risk. And so it's important to state that sort of distinction between nicotine and the other products within the cigarette. The addictive properties of vaping have often been sort of highlighted. However, we do know that people actually, when they vape, draw nicotine into the body in a slightly different way to the way they do with a cigarette. So people may feel like they're having to vape more often than they're smoking, but actually it's because smoking a cigarette is a remarkably effective way to get a huge amount of nicotine to your body very quickly. So your body feels if it Perversely, it needs a bit less of it than a vape, but actually the amount of nicotine and therefore all the other horrible chemicals you're getting in are huge with a cigarette. It's one reason why mild cigarettes are a swizz, because mild cigarettes, essentially, you just draw on them harder. So you get more of the chemical into your body. So they're a way of essentially saying, oh, there's a safe form of cigarette. Well, no, that's not true. A third myth is about disposable vapes delivering as much nicotine as 50 cigarettes. Actually, we have some of the tightest regulation on the amount of nicotine in a vape globally. So actually, you're getting a very small amount. Again, why people often do vape a little bit more. Vaping is a proven gateway into smoking. People do get very worried if people start vaping. Surely that will mean they'll start picking up smoking. You can find cases of people doing so. Of course, that will happen. But seeing as since 2010, when vaping became a bit of a trend, seeing as smoking rates have declined year on year, we would have expected by now for that progress to have stalled and in fact gone the wrong way, and it hasn't. And in fact, we can see a large number of people reporting giving up smoking and now vaping, and actually then giving up vaping. And then the last myth, which is nicotine damages brain development in young people. I think it's important to look at some of the studies on vaping and on nicotine and its effect on the body in the context of the hierarchy of evidence within science. So there are some studies quite highly publicized, often done what we would call in vitro, so in test tubes, but often then in animals, often mice, which show the harms of nicotine, which then are not replicated when we do them in human testing. So some other, I think these myths come from actually looking at the way in which the science is conducted, and generally we would put top of a hierarchy of evidence trials which are done across large numbers of people within a general population to see, you know, for those who vape versus those who don't vape, are we able to pick up any excess harm? Instead, a lot of the headlines have been that we tested 20 mice and found that, etc. And actually that isn't generally where we put the weight of evidence within public health. So the paper goes on to talk a little bit about some of the rest of the evidence and some of the regulation, and point 21, I'll hand over to Phil at this point, finishes in the words of the Chief Medical Officer, which I think if we take one thing away from today, I think it should be this: if you smoke, vaping is much safer. If you don't smoke, don't vape. So I'll hand over to Phil to talk about the rest of the services.
Thanks, Peter. So Public Health, we undertake a school survey every 2 years. So the last one was undertaken in the back end of 2021 with the results out in 2022. We've then replicated that at the back end of 2023 with the results being published in early 24, sort of just in the last couple of months. It's a survey of all of our schools across York are invited to take part, and it's the year groups of year 4, year 6, year 8, year 10, year 12. So in the most recent survey, there was just shy of 3,000 young people responded to the survey, and that's on a range of public health topics and questions, although we specifically included some on smoking and vaping. So in 2023, a quarter of young people aged 12 to 17 have reported ever trying vaping. That was up from a fifth in the survey 2 years ago. So there has been an increase there. But as Peter said, that's to note that that's ever tried, not just within the year. However, the majority report experimentation with a small percentage, 3% reporting use every day. Among primary school age children, the overwhelming majority have either never used an e-cigarette or never even heard of an e-cigarette. 90% combined have never used or heard of. Worryingly, young people across secondary and sixth form wrongly believe that vaping is either about the same or more harmful than using a cigarette. So, you know, there's something around the perception of a vape compared to a cigarette. And in terms of where people are sourcing their vapes from, most are either given to them by friends or buy them from friends or someone else. And the most sort of common type of device is a disposable device, which probably comes as no surprise. With regards to smoking, we can see a continued sort of downward trend in smoking prevalence. However, 90% of sixth form children have not smoked a cigarette, rising to 95% of primary school age children. So there is something to be said for that rise in youth vaping will be offsetting because some people are not smoking. So there's something about vaping versus smoking, and what is if you're going to choose to do one, what is the safer way forward? If people are going to do one, would we rather they vape than smoke? It's a consideration. And then there's just some statistic in there around the proportion of people who are also living with a smoker. So 20% of secondary school age children are living in a household where there's a smoker. 25% of primary school age children are living in a household with a smoker. I guess what this kind of summarizes is, as Peter outlined before, is this twin track message around supporting the use of a vape in a quit attempt to stop someone from smoking a cigarette. However, at the same time, providing that education around the harms associated with vaping and why we wouldn't want to vape if we weren't going to be a smoker. I've then gone on to outline some of the work that we do through the health trainer service, and specifically our smoking cessation offer within the health trainer service. I did want to highlight and just get in there that we're a really effective service. So we get a 75% quit rate within the service. So looking at people who set a quit date and then 4 weeks later, if they're successfully quit, 75% of them do achieve that. That's the 4th highest in the country. So we are achieving good outcomes there for our residents. And the service really is a person-centred behaviour change service, and some members may be aware that there's additional investment being attracted into the council for that service. So that service is going to grow over the coming years. So that is a real positive. Within the service, there's a couple of ways that we support people and different treatment options, I guess, that we give to people. A common one is NRT, nicotine replacement therapy, so patches, gums, inhalators, that type of thing. And then we do offer e-cigarettes as well, not disposable ones, refillable ones. But I just tried to outline there the sort of the different breakdown of people using the different devices. So just over half of people used nicotine replacement therapy only. 30% used a combination of most likely patches and an e-cig, and then 16% used an e-cig only. Interestingly, though, in terms of successful outcomes, the people using the e-cig only were most successful. We had the highest quit rate among that population group. So there is something to be said for utilising a vape as a quit aid, and there's some sort of behavioural science around that, around it mimicking the action of smoking, that hand-to-mouth routine. So actually, it's an easier transition for a smoker to make than perhaps using nicotine replacement therapy. In response to concerns raised locally, particularly through schools, through pastoral leads, and through sort of school leadership, we developed a package of support for schools with regards to youth vaping, so that the service now does support young people to stop vaping. So there's a specific offer there for children aged 12 and above. We can support them with nicotine replacement therapy, although more often than not, they're not actually addicted to the nicotine. It's more about the behaviour change around and unpacking that as to why children might be vaping. And additionally, we've created, working jointly with colleagues across the region, some resources for schools, so lesson plans, information packs, PHSE lessons, etc., to really give current, frank advice on vaping, and that's being distributed to all secondary schools across the city. Additionally, we've worked closely with our colleagues in public protection in the trading standards team, and during last year we put some money into public protection for them to develop sort of a retailer's vaping scheme, and that was designed to remind retailers of their responsibilities around vaping and the legislation associated with that, particularly around underage sales and sort of checking for illicit vapes. And they worked with all vape retailers. As you can imagine, vapes are prevalent across a range of different sort of places now. So supermarkets, specialist retailers, and sort of newsagents, corner shops, etc. So they did an audit of all the retailers in the city and tried to engage and visit all of those. In the latter part of 2023, they visited 8 premises and tried to make test purchases, underage sales. They were successful, I suppose, if you see it like that, in one instance. So there was one shop that did sell to someone who was clearly underage. I think they used about 14-year-old volunteers, and a prosecution's pending there. And then just back in March last month, they were able to seize over 1,000 illegal vapes worth about £13,000. So that was a really good seizure. I think for me, the surprising thing there was that was just from 2 shops in the city. So it really shows the scale of the problem. You know, if that was just in 2 shops, I imagine there's an awful lot more that hasn't been detected to date. And then the last thing I just wanted to get in there was around the Tobacco and Vapes bill, which is making its way through Parliament at the moment. Hopefully you've seen and heard about that. It's getting quite a lot of press coverage. It's had its first and second reading. Its second reading is where it gets voted on. It was voted through with a majority. It now goes through all the amendment stages, etc., etc. I think the key point from that one is around raising the age of sale. So someone who's born on or after the 1st of January 2009 will never be able to legally buy cigarettes, which from a tobacco control point of view, I think is absolutely fantastic. There's also secondary legislation there around restrictions on vapes and the the flavours, the marketing of them, etc. And then there's further legislation, environmental legislation being introduced to ban disposable vapes. And finally, there's some legislation coming through the spring budget around including a duty on vapes. So there's an awful lot going on in this space at the moment at kind of a national level and a local level.
And I'll just come in and say one last thing to draw members' attention to the annex, which is a case study of one of the clients we supported through the health trainer service, just to show for one person just how effective e-cigarettes were in their quitting journey. So it just gives a little bit of sort of reality really to that. Thanks, Chair. We'll finish there.
Thank you both. That's really helpful overview on the report. So I'm going to open to members for questions and comments. I'll kick off and then I'll look for indications. I wanted to ask specifically about the public protection element, which you've alluded to as being successful, but also a really small number, 2 instances that were found to be selling illegal vapes. And so you question in your report, or you say in your report, that there's further work to do, beyond budgetary constraints. What does that look like when you're talking to public protection partners, and how would you advise that could be targeted in some way?
Yeah, so you preempted the first thing, which is obviously going to be the budget and the capacity to do that. Absolutely. And if you speak to our colleagues in public protection, they would say that enforcement activity is time consuming and challenging to do. The way that they do it at the moment is being intelligence led. So actually gathering that intelligence so that they know that there's a high likelihood of when they do make a visit that they're going to have a sort of successful find. So I think there's potentially something around an awareness raising campaign around how people could report. If people will know where these retailers are and where vapes have been purchased illicitly, or where sales have been made to underage people, and so there's a real opportunity to increase that flow of data into the authority, and therefore public protection will be able to take sort of targeted action off the back of that rather than speculative, quite costly action. I know it wasn't on this specific topic, but 3 years ago we did a market research piece of work on illicit tobacco, and one of the questions as part of that was, where would people report concerns around illicit tobacco to? And I think that the number one source was to the police. And there's something about that data flowing through from the police, you know, actually how is that centralised and how does that make its way through into the local authority? So one of the considerations could be to look at how we articulate the message to report concerns and get that data flowing into the local authority.
And I would add to that one of the best ways, and particularly for if you don't know where your local authority is, for instance, or who to report to, it's Citizens Advice portal actually is the best way to report intelligence through into trading standards. That's what's the national recommendation. So yes, a Citizens Advice website, just to Google it there, it's a very easy form to fill out in terms of reporting anything to trading standards on this or other topics.
Okay, thanks for that. I think it's an important point about police. I know there's a local authority in West Yorkshire that is working really closely with the police to try to get those trading standards issues ironed out. And they've had a lot of success as well. So happy to pick that up with you outside the meeting. I will move on to Councillor Smalley, please.
Thank you, Chair. I mean, you basically asked what I was going to ask pretty much in terms of public protection, or at least I'll claim that. I mean, I had absolutely no idea. I mean, obviously, as councillors, we're always trying to get public protection to do sort of everything left, right, and centre. And yeah, on whatever page it is, I guess between paragraphs 40 and 44. Yeah, really, really, really good to see that. And I guess maybe I've missed it, but yeah, if there could be more promotion of the work that they've done there, particularly, I guess, the outcome of that prosecution, you know, successful or otherwise. Yeah, a really good example of sort of proactively going out and making vaping safer. I guess on other stuff, I guess, yeah, I have my own sort of family history in terms of, you know, both parents were smokers. Mum quitting when I was born. My dad sort of carry on smoking and trying sort of everything to sort of stop, you know, trying to sort of develop sort of garlic eating habits through to the gum, nicotine patches. Taking any sort of long haul flight with him was, you know, you have to keep a nervous eye on him in case he went for the emergency exit. But yeah, eventually it was vaping that sort of solved it, and he's, you know, not been smoking now for several years, and, you know, already sort of looks and sounds healthier. I guess knowing him, and I guess the percentage of people who vape who are a bit like him, the move to make vapes more boring and cabbage flavored, rather than sort of cherry and chocolate, and well, actually, I mean, I don't think he'll retake up smoking, but I think, you know, actually it was those exciting flavors that made that transition far easier for him. So yeah, I guess sort of personal history there, that, well, not that you're going to, I guess, solve that. Going back to public protection very quickly before I sort of finish off. Obviously, public health are one of those areas that are really quite innovative in how you spend money, how you get grants. The government, I guess, are never going to give public protection more money because it's not an area that ever wins a vote and, you know, looks sexy. But I guess, could there be a way, in the same way you work with ICB, NHS, could public health money, I guess, in the way it currently doesn't, top up public protection, or potentially working so with those budgets a bit cleverly, knowing that that's going to be a pressure for them when the new regulations come in? And then just on the smoking ban, it's totally ridiculous. You know, the idea that in however many years' time, a 44-year-old will be able to buy cigarettes legally and a 43-year-old won't, is just totally unworkable. And it's just a Prime Minister desperate to have some sort of legacy before he's booted out of office. It's not a sensible sort of way to, if it's that bad, ban it for everybody. Don't sort of create a sort of, yeah, an awful age-related discrimination about what you're allowed and what you're not. Just my personal view, and I know the two of you aren't really going to solve that or change anything, but yeah, I guess that point on public protection really.
Thanks, Councillor Smalley. And in terms of public protection, I think one of the concerns I do have about the approach to the tobacco and vapes bill is that that there is extra resource around public protection, but it's not clear at all actually where it's going yet. So the policy direction in terms of some of the money to stop smoking services has been very clear. We've had communication about where the resource goes. Arguably, putting that resource into local public protection teams is actually where it's needed. But instead, I gather that it's going into national trading standards bodies and HMRC, and obviously customs have an aspect of this. Some of it is about importing and the flow in, but it is also about enforcement in local areas. So certainly we're in regular conversations with our public protection team, work very closely with them. There are some elements of their work which do have public health funding vested. Some air quality work does, but we're very supportive of the work they do and try as much as possible to join up the pieces. And Phil mentioned sort of the intelligence-led stuff, so that what on a tight budget, what doesn't happen is they do sort of 2 weeks work of work with chops and they don't find anything because people got wind of it and hid the stuff under the counter or whatever, so that intelligence-led approach is the best use of their resource. So certainly we work with them very closely, and Matt Boxall sits on our Tobacco Control Alliance and is regularly sort of there to talk about this stuff. So hopefully that work is joining up.
That's great, thank you. I'll go to Councillor Baxter, please.
Thank you, Chair. So my point's relating to paragraph 30, where it says that 100% of secondary/sixth form children who took part in the survey said that they did not know where to get help to stop smoking, which is obviously very concerning, given that within that percentage of people who do smoke don't, and that really sort of concerns me. I mean, I only left school 4 years ago, and I know I didn't have anything at school. I would have had no idea if I didn't have a mum that works for an ICB and is obsessed with that sort of stuff. And that just worries me. That does that fall onto the teachers then to pick that up, who obviously are overstretched anyway? You said about sort of lesson plans and PHSE, but is that not particularly effective given that none of them know where to go for help?
Thanks, Councillor Baxter. And it's a classic example, is it, of all the great work we're doing and wonderful, and then we go and undermine it by doing a survey which shows that we haven't reached the people. And it's a concern to me. I absolutely agree. And I wish I could say a small sample size, but as Phil said, we did survey a number of thousands of children. So I think there's a lot of further work to do. A couple of things I'll sort of note on that are obviously that the lesson planning and the curriculum activity that we've put in, plus new duties within Ofsted frameworks and standards around PHCE and all of that, I hope will start to filter through in that the space on school sort of curriculum will be freed up for this type of stuff, and then we use our resources, which we've tried to disseminate as much as we can. Secondly, we do commission, but I've only recently started to commission the Healthy Schools programme, and currently I think we're up to 4 schools with an award, 3 bronze and 1 silver, and something like 10 or 12 schools which have submitted for awards. So schools in York are starting to get a little bit of support from public health in terms of developing curriculum, and the Healthy Schools programme has 4 or 5 different domain areas: keeping active, school food and healthy eating, and one of them is around sort of risk behaviours and all that sort of stuff. So I hope, sort of, I'm careful what I promise here, I hope if we were coming back in a couple of years, rerunning a survey, which we intend to do so, that number will have shifted, because we absolutely would like it to be the thing that comes. I guess I would say that, children and young people are not typically those who regularly sort of would be able to point to, services, I guess, out there to help and support. What I'd hope is that a good number of our children in York have those supportive pastoral structures to connect with professionals who know about our services. And certainly I would hope that it wouldn't be 100% of our pastoral leads, our school staff, who don't know about council support around healthy living. So that's another area we explore, as well as with the children and young people, making sure staff are aware. But if you wanted to.
Yeah, thanks, Peter. I was really disappointed when I saw that as a result. As Peter said, I know that we're really engaged with pastoral leads and our school nursing service through the Healthy Child Service. I know that we're integrated with those services because I've been and spoken to those people, and I've stood in front of them and as our service manager. But absolutely, for me, there's a real piece of work to do around this, and so I would be shocked if in 2 years' time that we haven't seen that awareness of our service change for the positive. I'm absolutely confident of it. So thanks.
Okay, I have got a couple of indications on this. If I could take those first, then we'll go back to the order that I've had members pop up. So I'll go to Councillor Wilson on this discussion, and then Councillor Bassey.
Thank you, Chair. So quite closely related in terms of schools. Really positive to read all the stuff that you're doing about secondary schools and getting those resources in. I was just interested to know whether you'd thought about doing it slightly earlier. So when I was teaching year 6, we had a kid bring in a vape. We then dealt with the behaviours that came with that, and it was shared with a group after school. But I wonder whether offering those sorts of resources to primary schools might be quite useful, so that if you have an incident like that, you can then, as well as dealing with the behaviour, talk about the issues with vaping. And also it's in the science curriculum. We do some lessons on drugs, alcohol, smoking, and it seems like that would be an easy fix if you could get into York schools with this little bit on vaping would be really useful to include, just to talk about the risks. That would be, I didn't know whether that was something you'd considered.
That's a really good point, made, Councillor Wilson. I was just asking Phil whether those resource packs have gone out to our primaries rather than just the secondaries. It has been majority secondaries we've reached out to. You're absolutely right that, you know, someone who's currently looks after an 11-year-old, she, I think, is exactly that age where we need to start talking about this. And, you know, having a dad who's Director of Public Health means you can't hear anything but stuff about healthy eating and smoking and vaping. Bore her to tears. So I absolutely think that a top end of primary school is probably where this needs to head. And of course, that then brings in our, as Phil sort of noted, health visiting service, school nursing service and health visiting, which increasingly is going to take a 0 to 11s approach. So we'll stretch across the whole of primary age. So I think, again, another great sort of nudge from the committee to look sort of what's next in terms of this work.
Can I bring Councillor Bassey in, and then I'll come to you then, Phil? Is that okay? Yeah.
Yeah, I've been interested in what's in. I'll start again. I've been interested in the discussion so far. Yes, it leaves me thinking, when the next survey takes place, can it be specifically designed in order to disseminate information, but also to acquire consent of participants who might be happy to help communicate peer-to-peer what's been discussed, since we've got 100% of people not knowing about it? Because they're maybe the most effective communicators of what vaping is and all the issues around it. And then it also makes me think of climbing out of silos, and just wondering whether a bit of looking around could identify young filmmakers who could make such a film, with young people talking about what the issue is and what they've learned to each other, and maybe looking down the road to assembling a 1-minute film that can be showed at the city screen, etc. Just thinking more laterally about not having bureaucratic communication, but peer-to-peer communication.
Thanks for that, Councillor Bassey. Phil, did you want to come in on the general schools discussion, and if you want to touch on Councillor Bassey's point, that'd be useful.
Yeah, absolutely. Just in response to Councillor Wilson, there's something around our service at the moment and its suitability for supporting young people. That was part of the decision making for not going into primary school at this moment. It's not to say that we couldn't in the future, just NRT is currently licensed for children at 12 plus, those types of things. So there'll be some practical considerations, but I absolutely take your point, and yeah, we'll do some action on that. With regards to Councillor Bassey's point around a video, I think that's an excellent idea. We did produce an animation around vaping and, you know, the why you wouldn't vape, why you might vape, etc. And we did seek advice from the Youth Council on that. And the message that we got back from them was, this isn't scary enough. It's not stark enough. So we went away and learnt from that and did modify it. But absolutely, I think
it was narrated by.
Yeah, it was narrated by a young person at one of our secondary schools as well. So we did utilise that, but we could elevate that in the future. Absolutely.
Thank you. Just pleased to bring in our executive member at this point, Councillor Coles.
Oh, thank you, Chair. I just wanted to draw people's attention, because it hadn't come up yet, to paragraphs 32 and 33 around the success of the health trainers, and the fact that we do have the fourth best quit success rate in the country. That is something that we should be shouting about. And from my ward, I know what a positive impact it has. People coming up to me asking to get the health trainers in, people who've smoked for decades, asking for support to give up, knowing that the support is available, that it's being provided by the city. We should be really proud of it, and we should shout about it a bit more. And I was just going to touch on, I know that the tobacco and vapes bill has been quite challenging for opposition councillors, because I know that it's an issue on which they are divided on the public health benefits of it. Certainly from where I'm sitting, it's about preventing future public health challenges, reducing health inequalities. It's not about banning things. It's about stopping people doing something that's really damaging to their health. And if we weren't going to do this, I guess the question is, what would we be doing that would have the same kind of impact? And certainly as a parent of a 13-year-old, if you ask me, it's one less thing that you've got to worry about as a parent. And it is something that as parents, people do worry about, is whether their children are going to take up something that is incredibly damaging to their health. And I think we should be celebrating the efforts of the health trainers that are doing that work, but also doing what we can to try and prevent those health challenges further down the line, in my opinion.
Thanks for that, Councillor Coles. I've got another indication there. I do want to come to Councillor Runciman though, because I know you've been waiting a long time. Oh no,
you go.
Right, back on public protection. And I don't know the answer to this at all, but I know that they look at underage sales, but do they send anything for analysis to see what's in the vapes?
They do if there's an indication that it might be anything untoward. So we have the ability as a local authority to send it across to I can't remember the name of the lab. It's a lab in Manchester for testing of substances. Again, it wouldn't be routinely done on a sample of 1,000 vapes. It just wouldn't be feasible to send them all off. However, if there was specific intelligence around the vape and its contents have either been not meeting the criteria in terms of its nicotine strength, its nicotine volume, or it containing another substance, then it could be sent off to the lab to be tested. I believe our colleagues across sort of York and North Yorkshire have sent devices off to be tested, but none have come back necessarily containing untoward. I think it has been known to be devices containing other substances in other areas, but not, as far as I'm aware, locally.
And I'll just come in on that, Jeff, if I may, just to say that one of the things we are particularly watching out for is synthetic cannabinoids within vapes, and that has been seen nationally. As Phil said, the Manvape programme in Manchester, where we send the tests to, has had a number of samples back from York, which have actually shown it was just nicotine. It might have been higher strength than is under the regulations. However, that is something we are very much watching out for. They'll also, public protection, be able to obviously measure the quantity, and one of the things within a vape is it can only be a certain amount, so they'll be able to look at sort of the raw quantities of in vapes and understand also whether seals have been tampered with. So there's a lot you can do, I guess, without doing a full sort of chemical spectrum analysis of the vape.
Yes.
would the police alert you if they thought that something untoward was going on with vapes?
One would hope so, Councillor Runciman. I think we have the police on our Tobacco Control Alliance, but I think inevitably there's the amount of reporting that goes on will be underreported, those types of issues you're talking about. So one would hope that the police do have a really strong relationship with trading stands, would have officers who deal specifically around enforcement. But I guess what you're looking for is every neighbour policing officer, PCSO, etc., within the force area, of which there are probably many thousands, being aware of potential risk. And I'm sure they themselves would probably say that there's always going to be underreporting and that not seen as so much of an issue. But we'd hope as awareness increases, and particularly when there are those harms and risks to health and also criminal elements, if you fill a vape with synthetic the spice type substance and sell it to someone, give it to someone, you're committing an offence. So there are criminal aspects to this which they are likely to pick up. So I couldn't speak for them in terms of the amount of resource they're able to give to this. I suspect it's not as much as we might want.
Thank you, Councillor. Okay, I will just bring us backwards a little bit and just say, maybe you've thrown me a little bit of a leg break in bringing up the smoking ban, as it's known. It's the tobacco and vapes bill. But I did welcome Councillor Coles's point of view on the matter, which I share. I only wish maybe it would have come in how many years ago now when I picked up smoking. Anyway, I'm not a smoker anymore, but yeah. But that's my personal opinion. I thought I might try to bring Councillor Burton in, who did indicate.
Slick. Yeah. Yeah, it was only a quick one following up about the health trainers. Yeah, great. See them, the outreach team, I guess, I don't know how you describe them, but down at Town Hall Community Centre when I've been doing surgeries, and I guess it was just an opportunity to ask, do you take invites? Are you looking for, if there's places that you aren't currently attending, is it possible, do you want councillors to kind of feed into you and look at how we can get you along? How does that work?
Absolutely, yes, please. We are looking at how the service is structured currently in terms of our delivery model, and we are really keen to get absolutely embedded into communities and take the service to our residents who we are not serving at present. So the service is, as you say, distributed across the city, but I still don't feel that we're really getting into the hearts of the communities. So yeah, if councillors have suggestions of venues to utilise, please do put them forward to myself and Service Manager Glyn, and we will absolutely take you up on that.
Okay, Councillor Burton threw me a googly as well, because I thought you were coming in on the smoking ban. So I gave all that preamble for no reason. Okay, anyway, thanks for that. Councillor Steels-Walshaw.
Thank you, Chair. It was just a bit around the myths, and absolutely the myth that vaping isn't more addictive than smoking, but within that absolutely acknowledges the physical side of addiction, but the psychological side of addiction is very, very big with that. And I just wondered if within the work the health trainers do, I mean, you did speak, Phil, about the hand-to-mouth thing and all that, but are there only other specific psychosocial interventions that are done along that, aside that, to either stop smoking, stop vaping, look at kind of the things around people's addiction and why they are continuing or even started to do it in the first place? Thank you.
Yeah, absolutely. So I guess a core part of what the service focuses on is the behaviour change associated with smoking. So as you'll be well aware, there's sort of three facets to there's addiction, the habit, and the behaviour, and we call it the addiction triangle. And so the service really utilises that as the sort of the foundation of the discussion with service users. So you know, the addiction part is the nicotine part, and that's the part that we can mimic with NRT or with e-cigarettes. Actually, the habit and the behavior part are the bits that people often don't necessarily understand, and that's where the health trainers really try to engage with individuals to help them to change those behaviors and change those habits. So in that regard, that is why vaping is so successful, because you're not changing that habit and behavior necessarily. Behavior might be changing in terms of where you vape, etc., but the habit is still there. So longer term, as we hopefully look to extend our offer in terms of the duration that we support individuals for, it will be to looking at getting to that 4-week point where you quit, you successfully have stopped smoking, and then what do we do beyond that for the next sort of 6 to 8 weeks in terms of titrating down the dose of nicotine that people are using, and then actually coming off the vape long term. So that will be the long-term plan for service users coming through who want to use a vape.
Well, just if I might add something to that as well, which is that I think one of the things we know about addiction is that, you know, humans are very prone to it, and sometimes one addiction ending can be the start of another one. I think vaping is a good example of that. But people will often say, and it's addiction is maybe not the right word to use here, but just in terms of health behaviours, you know, a typical thing that an ex-smoker says is, "It's great that I don't smoke, but the problem is I put on loads of weight." And we often have that as a worry. It's one of the reasons actually the health trainer service, which today I think has got the attention on smoking, is actually a holistic wellbeing service. It thinks about people's alcohol consumption, it thinks about people's smoking, their physical activity, their diet, and also their social connection and isolation, and how they connect into the community as well, which probably is the thing in the long term that will lead to the best health, is thinking about a person as a holistic being and helping them and supporting them. And I know, you know, this smoking has been the focus and vaping of the paper today. Smoking rates are heading in the right direction for the city, whereas people who don't have enough physical activity, who have a poor diet and who are overweight or obese, is going the wrong direction. We're now getting more than 50% of our calories from ultra-processed, dense food, low in good nutrition and high in fat, salt, and sugar. So I think there is definitely something about seeing public health issues not in isolation, and even adding to the 5 the health trainer service think about gambling as a public health issue. We think about sleep as a massive determinant of health for the individual that we don't concentrate on enough. So I think there are a number of areas in which the health trainer service, I think, is looking to grow and expand beyond what we've mentioned here, and sort of welcome, you know, future discussions at committee about how we can best utilise that resource, really.
Thank you so much. Okay, members, Councillor Melling, yeah, please feel welcome.
Well, it's not really about public health, so I wasn't sure whether it was a point to make, 'cause it's a bit off topic, but
Row it out there.
affects other departments. I think different departments should work together. So do you mind? Yeah, thank you. It was just like a little bit of an issue about wording. So, you know, like with flushable wipes, they're not flushable. They call people flushing them causes all sorts of problems, but they keep being called flushable wipes, so people think they're flushable and flush them. I think we have a bit of a similar issue with the term disposable vapes, because they're not disposable, but people keep calling them disposable vapes, and they cause all sorts of, you know, they cause people put them in their normal bin and they cause fires and bin lorries and waste sorting centres. I think we had a fire not that long ago which caused hundreds of thousands of pounds of damage, and then it also impacts, while the very expensive repairs are being done, it impacts on the council's ability to collect people's household waste and that sort of thing. So I was just wondering whether in your kind of public communications about vaping, whether it, like, you know, if you use terms like single-use vapes or non-rechargeable vapes instead of disposable vapes, maybe you would be not adding to existing problems with that term. The surveys have shown that most people don't realise that so-called disposable vapes have batteries in and that sort of thing. So I was just wondering, you know, just a point about your communication wording.
I think it's a great point, Councillor Meadow. I think, yes, the single use, you know, kind of throw away, maybe even, you know, that kind of, because you're absolutely right, they have caused huge issues. I think it just to draw attention to the fact that one part of the legislation, the fact that the bit of the legislation is probably going to move the slowest is around the ban of what's called disposable vapes in the national sort of legislation. That's why I've used the phrase, and they will increasingly hopefully be off the streets. We, in our services, don't use single-use vapes. We give out refillable. That's part of our offer. That's what we'd encourage people to use. I expect that the single-use vapes will remain almost identical in the UK on the market, apart from they have a little USB charger point at the bottom that the companies will add. They'll probably still be used only a few times and then chucked away. So I don't think the issue, unfortunately, is going to fully go away with the legislation. It's possibly the weakest bit of it, but we can certainly do our bit to try and emphasise that there are environmental aspects of this. You know, people smoking is an awful thing, and unfortunately, we've got to use a little bit of plastic to get them off. But let's use refillable plastic rather than single use.
It's a really good point, Councillor Mace. Thanks for raising it. And I'll bring in Councillor Vassy.
Just following up that, we haven't actually talked about cost really. And part of this bill I notice is about increasing the cost of vaping. I know from a friend of mine who was smoking 50 a day until quite recently. I think that's 300 quid a week or something they were spending on cigarettes. I'm just keen to find out what impact you think there will be on vaping in the city as the cost of vaping goes up, whether we're talking about getting rid of disposable vapes or simply increasing the cost of all vapes. What impact do you expect to see?
Yeah, I mean, the cost will inevitably go up, but I think the justification for that is they call them pocket money prices, you know, and they're really targeted at such a low price point that they're targeting children and young people. You know, a £1.99 for a single-use vape is absolutely priced to appeal to a child. I think you raised the point there about actually if someone is already smoking, they're already used to a level of cost. And actually, even with these increases in costs on the vapes and the duties that are going to be put on e-liquids, etc., that wouldn't breach the cost of smoking. And they have the sort of the duty escalators, they call them. And however much the vape escalator goes up, cigarettes will go up by more. So proportionately, even going forward, as time goes on, as the cost of vapes rise, so will the cost of cigarettes by proportionately more. So the appeal to a smoker to switch from a traditional cigarette to a vape should still remain, whilst making it less attractive to children and young people. That is the policy aim, and I believe that that should be met.
Thank you for that. That's really, really good point. Okay. So drawing this one to a close, I think I've picked up a couple of agreed recommendations, which I'll just throw out there just for the record. There's probably more, but I've got two which we should place, which is to recommend a review of information packs. I forgot what you called them, but a review of information packs for potentially for primary schools. And I know in your answer that you said, you know, they're not designed for that, the contract's 12 plus, etc. But I think you made a point around year sixes. And so if we could, we don't need to be too specific, but something around a review for information packs for primary schools. Mm-hmm. Okay. And then last recommendation will be to work with counsellors and community partners on a word for health trainers to promote the work of health trainers. Does that make sense? Work with counsellors and community partners to promote the work of health trainers. Okay, we've got that. Councillor Vassy.
Just to add to your first recommendation, we also talked about or I certainly raised the issue of peer-to-peer communication, and you responded well to that, of getting young people to help in the communication, and maybe when we're surveying them, to get their consent to participate in helping to disseminate best practice and understanding.
Okay, happy to add that. Let me just just get that clarified for the record. So you wanted to add in a review of the information packs for primary schools and what for to look at peer-to-peer communication.
To use the next survey, because it relates to a survey in here, to use the next survey
Yes.
to engage with young people to get their help in communicating what vaping's all about.
Okay.
That's the basic idea.
Have we got that, James?
Yeah.
Perfect. Okay. I think we can move on from this committee. I would just like to end by saying to both Phil and Peter, on both items, really appreciate the reports, the engagement from you, really high levels of assurance and confidence from my perspective that public health is doing a really good job and direction of travel's just going in the right direction. So thanks again for all your work. Okay, we will move to work plan, which is inevitably got a few slippers on it. Okay, so let's look at the page number that you've got, and then I've got a little bit to add to it. Page 37, work plan. Okay, I might go to James. Let's go to on this. Is that all right, James? Yeah.
Okay, so I think in what members have got in your agenda pack for the work plan, it just covers the next meeting to May. I think with that one, there was a suggestion from officers in adult social care to take off the reablement item. The logic of that was that there hadn't been any changes to the sort of reablement position since the last report, which I think you had in November. So they were suggesting to remove that for now. I think going back to sort of how that had found its way back onto the work plan, I think it had been a suggestion to have a piece on reablement technology specifically, and then that kind of expanded out. So I think we're now looking at I think it was a suggestion a couple of meetings back to have an external expert in reablement technology to come and talk to the committee. So I think we're still working on that, and I think hopefully there'll be perhaps an update on that for the next meeting. But I don't think that would be you probably wouldn't have that person at May. It'll probably be for a future meeting. So I think that was a suggestion to members from for the May meeting. I guess, and you might want to maybe say a bit more on this, maybe, Chair, but I think the with a view to looking at the work plan for 2024-25 year, perhaps we could we've had a couple of suggestions for things that might slot nicely into June and July, and then perhaps we could maybe come back to the next meeting with a more worked out draft work plan, if there are sort of more things in the meantime. So I just mentioned the things for June and July. I think the homelessness future resettlement pathway report was mentioned earlier. My understanding from officers in housing is that that probably will be available for either the May or the June meetings, and June following what the committee has been doing so far with sort of themed meetings. June would be the next housing one, so that might be a logical place for that to maybe fit. Then with July, that would be the next public health meeting. There's a couple of things here, and I think Peter is aware of some of these. There's been a suggestion it was actually a suggestion from a member of the public commenting on one of the webcasts on YouTube of a previous meeting of the committee, suggesting that the committee have an update from the York and Scarborough Hospital Trust on its improvement plan. I think it's the Back to the Floor campaign. I think you'd had a previous update on that in I think it's September last year. So we've checked with the trust, and they'd be able to bring that in in July, if that was something members were interested in having at that meeting. The other items, pharmacies, had been moved from this meeting, so that could potentially, I'll just leave it to Peter maybe to sort of say more on this, but that could potentially be there in July. And then the other item was breastfeeding friendly culture update, which members had asked for off the back of the infant feeding item in December. I think members will have received an invitation to a Yorkshire and Humber infant feeding event. And that's in July, I think. So that might fit neatly to have that report at the time when you potentially be at an event on that. So those are the things that we'd sort of done a bit of work in the background on to see if they would be available for July. So just to sort of highlight those. Yeah. Thanks.
Okay, thank you so much, James. That's brilliant as ever. I'll just bring in Peter on that, please.
Thank you, Chair. I think one other suggestion that James and I discussed, but I wasn't entirely sure what members wanted, was around children's healthy weight. I think the suggestion potentially would be that the Children's Overview and Scrutiny Committee and this Overview and Scrutiny Committee might both be interested in that. Is it an opportunity for perhaps a joint scrutiny on that? I'll leave that with you, but that had been raised with me as a potential idea too.
Yeah, that's brilliant. We have been contacted about that, haven't we, Councillor Vassy, as Vice Chair and Chair from the Children's Scrutiny Committee. And so, I mean, I'd be really keen to do a joint scrutiny topic with children's on children's healthy weights. And I don't know if you've got a view, Councillor Vassy.
I'm just thinking it'd be good to have a steer from you, Peter, just on. Sometimes I get the feeling we're challenged by not knowing necessarily when our input can make the most constructive contribution to getting something to happen, whether it's within the local authority or within other agencies. So I'd be very happy to just hear your thoughts on how all this timing is most constructive to the wider picture.
Absolutely, thanks, Councillor. I think tonight's meeting has actually been very well timed for the two topics, particularly the vaping topic. So there's a good illustration of that. And I would say actually that that having a scrutiny discussion around children's healthy weight in the summer to early autumn time would be very welcome, because we are doing some review of our work in that area, and also I think the NHS too, looking at its weight management pathways for children. I think it's timely to think about that before the start of next financial year 25-26. So that I would say would be really well timed for that particular piece of work for scrutiny.
That's good to hear, and it would be good to get an idea in that report of the kinds of recommendations that would empower the local authority to have a strong hand to play. So that would also be, I think, welcome.
Okay, that's a really good point. Again, we can pick that up as we work to arrange this with Children's Scrutiny Committee. Looks like it would likely be an additional meeting. If summer, autumn would be good timing, then we could look at the future calendar, but at this stage it could well be just an additional meeting or one-off where we'd all be invited. So on that, I'll say we're happy to agree that as an idea in principle. On the work plan, happy to agree the May meeting, what's published on page 37, but removing the reablement topic, which will slip into, and it is on page 37, it's slipped into a bullet point under the sixth one down, which is external expert on reablement technology. So we've still got it on the record. And then we will publish June and July the suggestions made by James, our democracy officer, to bring forward homelessness in June which is homelessness future resettlement pathway. The executive member mentioned it will be ready at this stage. And then we'll seek to add items to that agenda around the housing topic. And the July topics to be published on the record are the York and Scarborough Hospital Trust update, which is well overdue because we did the CQC last autumn. So it'd be good to get an update on the various recommendations that they're working through. Breastfeeding friendly culture, as James alluded to, everyone should have had an invite to that. It's an event at York St John University.
Has that invite only been sent to members of this committee, or has it been sent more widely to other councillors?
Just this committee.
Is it something that's also relevant to other councillors?
Yeah, it arises from an agenda item that we worked through, but I think in principle, there's probably no reason why all councillors couldn't be invited. Let me pick it up outside of the meeting with the organisers to work that one out.
Or maybe at least substitutes.
Or invite or interested parties.
Yeah.
Let me work it out. But if you are here expressing an interest, I will certainly get back to you on that.
I mean, I haven't seen the invite, so I don't know exactly what it is, but if it's something that's relevant to residents in all our wards, not just people who are involved with health policy, yeah.
Yeah, okay, we'll follow that one up, okay. And then pharmacies, that will be published on 10th of July in the schedule as well. And we'll leave it there. We will have a more fuller discussion, as James says, at the next meeting on the 15th of May about what an annual work plan will look like. I think we've had a good municipal year, got through lots of topics, so thank all of you for your help with that, and we'll look to do the same in the next one. I think that's everything, unless anybody's got anything to add on that item, and I'll move to urgent business. Is there any urgent business from members? There isn't. Okay, I think that is a great meeting. Okay, thank you everyone for your time and contributions. Much appreciated. Have a good evening.